we have Elder Shane Pointe joining us, Dr. Mary Ellen Turpel-Lafond, and Harmony Johnson to speak to us today on International Women's Day, on the Indigenous women's experiences from the report In Plain Sight, addressing Indigenous-specific racism in BC healthcare system. Dr. Mary Ellen Turpel-Lafond is the academic director of the Indian Residential School History and Dialogue Center at the University of British Columbia. She's a lawyer, a former judge, legislative advocate for children's rights, and professor at UBC's Allard School of Law. She holds a law degree from Osgoode Hall at York University, a master's degree in international law from the University of Cambridge, and a doctorate of law from Harvard Law School. Harmony Johnson of the Tla'amin Nation and of Coast Salish ancestry. She brings over 15 years of experience in executive and senior roles in health and First Nations policy, intergovernmental relations, and self-governance. She is also the author of a number of publications, including the book, Written as I Remember It, Teachings from the Life of a Slam and Elder. I'll now pass off on to Elder Shane Pointe to introduce himself and also start us off in a good way.
Thank you very much. What I think is interesting and new about this form of communication is the use of pronouns. And I look at the screen and there are people and they're saying pronoun. And I often wondered what that meant. And I was talking to my nephew today and I said, well, I'm going to start going by the pronoun uncle. Uncle's a good pronoun, so pronoun. I want to say to all of you, I've led an interesting and wonderful life of equity. I grew up in Nanaimo, British Columbia. I grew up in an environment that required that my mom, my dad, their peers worked in concert with each other. Our community, our village, was one of equity. I seen it, I was a part of it. My uncles, my granduncles taught me those things that I needed to know as a boy, a big boy and a man. As well, my aunties were in charge of teaching me, as well as my mother, to be a good human being, wonderful human being. Throughout my life, I have gotten to do many things because of that equity. Within my own community and family, I get to do what I'm doing at this very moment because my aunts moved me along and my uncles taught me what it is to do. I believe for myself it's of the utmost importance to bring Nutsamak, we are one, to everyone. For the past 10, 15 years, I've been using that word, Nutsamak, we are one. We are one. And I truly believe that. And it's been my work, my sacred work, to bring that message to everyone I meet and to every moment such as this, every important moment such as this. Equity is of the utmost importance. My age peers, my aunts, my daughters and their peers, my granddaughters, and their peers in Canada have suffered the most. And that's just wrong. I do this work and I help as much as I can so that my great-granddaughter, Thunder, can live a good life, one without worry, one without hurt or pain to herself because of who she is. It's a great honor and a privilege for me to be with all of you. I've had an opportunity to work with Harmony when she was a part of the First Nations Health Authority, and had a brief opportunity to work with Mary Ellen, someone that I admire greatly when I listen to her accomplishments. She sounds like my mom, my aunties and my grandaunts, women who put the needs of others before them. So it's been wonderful for me to meet her, be a small part of her work life. I want to say to all of you, I'm proud of you. Whatever it is that you do in terms of your work, how you use your educations, use them to help. Use them to help those less fortunate than yourselves. My dear friends and relatives, in welcoming you to this moment, I'm asking the infinite and our collective ancestors to please open our hearts and our minds to the Snowiath, the teachings that we're going to hear. Open our hearts to them. I'm also asking, please, please, not so much swallowing. We are one heart and one mind. Bring us, please, to that one heart and mindness so that we're good human beings, strong human beings that know, believe, and value that we are all equal, that we all cherish and treasure each other. With that, once again, I want to say I'm proud of all of you, and I am happy to be with you for these few moments. Please open your hearts, open your minds. Thank you very much. Thank you.
Thank you so much. I'm going to just jump in and first of all say thank you, Shane, for those remarks and the song, and also to remind us on this incredibly special day, International Women's Day, as we're celebrating the many achievements and ongoing challenges for women, particularly in health and in equity and equality, how important it is to have a sense of being grounded and just being totally present in this moment together in our virtual circle. And I'm just really proud to be here today, and really thank you. And also like to acknowledge and express my appreciation for Shane, who provided cultural support to Harmony, myself, and a small team that did provide an assessment this past fall and early winter of the British Columbia healthcare system. And I want to acknowledge my colleague, Harmony Johnson, as well, and just say how much fun it is to be together on International Women's Day, and to recognize how important it is that, particularly as First Nations women working together in something that we feel really passionate about, and in particular, trying to get and lift up the voices of First Nations women in British Columbia, and Métis women and Inuit women in terms of their experiences in healthcare. And also looking forward and having a chance to talk about looking forward about how we can strengthen fairness and justice and respect and cultural safety for Indigenous women in healthcare in British Columbia. It's so important. It really is the biggest learning that we had when we looked at the issues of racism in the healthcare system in British Columbia. Two things. One is how, and I'll talk about it a bit, how harsh the system has been on women and the lives of women at the point of care, but also how much contribution women are making every single day in health careers and health professions and navigating the health system for their families, and often experiencing, even as professionals, racism in their working life, and that intersection of racism and gender or sex discrimination, and how together it has been so destabilizing in terms of being able to provide safe care. So it's really important on a day like today to both acknowledge and tell the truth about what we found, but also to really lift up. And I know there's many people in our virtual circle today who are working in various roles in healthcare and leadership in healthcare, and really want to say thank you to those who are for supporting the review that we did, but also for doing important work and building change. And also to the center. I really want to say thank you so much for the center for having this event. And it's wonderful to have a day that can intersect not only with, so your passions and your work in life, but also to bring together people who are poised and working in an area which is fully within our control to transform and change, to be more respectful for women and for First Nations people, and also to give space. So I really want to acknowledge that and thank Brittany for her introduction as well. So I'm going to talk a bit about the review that was released in November. There was actually 2 reviews. One was released in November and one was released in February, which was really looking at data or evidence. And Harmony and I want to talk about this a little bit today and give a chance to answer some questions, promote that you look at it and think about it, because although we didn't fully at the outset think it was going to be a report around women's health, it ended up being very significantly a report about the experience of women in the healthcare system as patients, as workers in the healthcare system, and as mothers, daughters, sisters who could not get the kinds of supports that they need, despite the fact that we have a very strong healthcare system in many respects. So next slide, please. So first of all, I want to just give a trigger warning because the topics we're going to talk about are quite triggering. And again, I'm just so grateful for the support of Shane and the number of First Nations elders and cultural advisors who provided support to us and cultural support to us while we were doing the review to let us just even together process this, because when we started to look at the issues of racism in British Columbia, it was incredible how much material came forward and still comes forward, because we still have a 1-800 number. We still take in cases and complaints and they come in regularly. But there is emotional support and there's mental health assistance. And I want to recognize and thank First Nations Health Authority and the Métis Nation of BC, both for making sure that those services and support are there, including to you if you're triggered by this report and our presentation today. Next slide, please. So what we looked at is we really looked at the quality of the experience for First Nations and Métis people in British Columbia at the point of care, meaning where you actually get care. So where you go into, whether it's a hospital, a clinical setting, a dentist, that's what we really looked at. Next slide, please. And we had a lot of input. Sorry for all the little dots on the screen, but we had surveys and engaged with, actually it was nearly 5,000 Indigenous people. Full surveys that we used in the assessment was about 2,780. Many Indigenous people reached out to us, started the survey, couldn't complete it, and called and talked to us about their experiences. Some of those experiences were historic, something that had happened to them in the past. Many were things that were going on in the moment, and many were the combination of both. And the majority, as you can see on the screen in the text box on the right, the majority of people who responded were women. So more than 70% of the respondents to all of the Indigenous surveying were Indigenous women. In terms of the health workers, we looked at all health workers in British Columbia, and we encouraged them to tell us how things were working, how racism, if it was present, was presenting itself in their workplaces, how it directly or indirectly affected them. And again, we had more than 5,000 responses. Again, 80% of the responses to the health worker survey were women, and all of the responses to our call line, 70% to the phone and email, were women. So what does that say? That says that there was a lot of women, Indigenous and non-Indigenous, who were very keen to inform the review process and who did inform the review process. And for Harmony, myself, and the small team that was tasked with this role, we really had to listen, of course, and learn and understand the experiences of women and how they were bringing forward systemic issues, individual issues, and the combination of racism and gender discrimination together. And it really is an intersection. We also did quite a bit of interviewing and reviewed the literature. And again, although we have had some important literature and writing on Indigenous women's experiences in health, it is just scratching the surface. There is so much work to be done, which is, I think, why the center, in particular, the Center for Gender and Sexual Health Equity, is such an important center. And that's why I'm really proud to be here to celebrate International Women's Day, because this is so important to continue the work and to lift up and support research, scholarship, and ongoing activism and work for women. Next slide, please. So some of the key concepts, and again, when we have a lens to respect and understand gender discrimination and sex discrimination and racism and how they interplay for Indigenous people, the review specifically was asked to look at anti-Indigenous racism if it was present in the healthcare system. And we did find anti-Indigenous racism, and we'll talk about it shortly, but it was really layered together with discrimination against women in particular. So we looked at prejudices and profiling, and there's a specific profile that we found that was very common in terms of Indigenous women in the healthcare system, which affected their access to care. We also found a significant issue around privilege, namely privilege meaning whether or not the healthcare system, and especially in the care system in the clinical environment, if it is a safe place to talk about racism and sexism, and whether or not people's voices can be raised up and issues can be addressed in the workplace effectively to support patients and to support staff. And privilege really, I mean, obviously in healthcare, people hold privileges, but the issue of privilege, of whether or not leadership in healthcare has used the privileges it has to allow us to have this conversation, is something that we were really struck by. And how the racism and sexism that has been there is so strongly acknowledged. And once we opened the door to hearing about it, it was enormous. It was a tsunami of cases and complaints that came forward that hadn't been dealt with for a long time. But it really did cause us to reflect on privilege in terms of leadership in the system, and whether or not that leadership is being exercised in a way that is listening to that, and the need to make shifts there so that it does. We also in this report talk about different sort of mindsets, practices, and tools. So to be anti-racist is quite significant in terms of understanding the experience of Indigenous people and responding to it. To promote cultural humility, we'll talk a bit more about what that means. And the issues of cultural humility and cultural safety are terms that are bandied about a lot in healthcare, frequently with no understanding. And often we've had people say, this is a culturally safe environment, but women are all like this. And so you're like, well, I'm sorry, it's not both culturally safe and gender safe. And some of your thoughts and beliefs that inform service provision at the point of care require some new mindsets, tools, and practices to address these issues. We really looked in the review at the UN Declaration on the Rights of Indigenous People, which, as you know, was adopted to be implemented into the laws of British Columbia in 2018. And in particular, Article 24 is about the right of Indigenous individuals to have access without any discrimination to all health and social services. And as well, there's other articles that are very important. Article 22 and Article 20, in particular, Article 21 and Article 22. Article 22 of the Declaration speaks to the right, particular attention needs to be paid to the rights and special needs of Indigenous elders, women, youth, children, and persons with disabilities in the implementation of the Declaration. So we really looked at it from a rights-based lens, and the need to realign the system so that the discrimination and experiences that Indigenous people have can be brought forward and addressed, so that Indigenous individuals can have an equal right to the enjoyment of the highest attainable standards of physical and mental health. And so in terms of the outcomes that we were really looking at in the system, we were looking at substantive equality. And that's from both a gender lens and a racial lens. So that, for instance, Indigenous women may not have the same starting points as non-Indigenous women, but through healthcare access and utilization have substantive equality. And that requires us to do significantly more in terms of making health environments more welcoming, more safe, and more oriented to the needs of women. Cultural safety we'll talk about, and so protecting the rights of Indigenous people. So these are some of the key concepts you'll see really unpackaged in our reports, but it's really important to talk about the interplay of racism and gender discrimination, because it almost cannot be teased out, because they're so connected, and they so mutually kind of reinforce each other in the British Columbia healthcare system. Next slide, please. And so just in terms of what we heard back about racism and discrimination, more than 84% of the Indigenous respondents, remember that's primarily women, reported some form of discrimination in healthcare. 35% of the healthcare workers responded and had witnessed interpersonal racism or discrimination. And that was 59% among the Indigenous respondents only who were healthcare workers. 52% of those Indigenous healthcare workers reported personally experiencing racial prejudice at work. And again, sometimes that was very gendered, in particular, very gendered manifestation of that racism. And of all the healthcare workers that we surveyed, 13% or 531 made racist comments in the survey, meaning they made comments such as they maybe identified an instance of direct personal racism, but then made a comment like, but you know, those people are like this. So repeated profiling and repeated attitudes that really need to be eliminated through anti-racism and anti-sexism tools in healthcare. The top reasons why racism persists is not employees not willing to speak up, and of course not supported to speak up, lack of accountability by leadership to stop discrimination, and insufficient numbers of healthcare professionals. Next slide, and I'm going to turn it over to my colleague, Harmony.
So we also wanted to understand not just that whether racism exists in healthcare or not, but also where it comes from, what it looks like, and what holds it in place. So this infographic in the report was intended to try to provide an at-a-glance look at that. So this kind of covers a number of the findings in written form in the report. So if you're starting from the top left-hand side of the diagram, we as Indigenous peoples come from strong systems of medicine and governance in our communities that kept us well and thriving for generations. That was supported by medicine, by science, by knowledge. And through processes of colonialism, those systems were oppressed and undermined. And that oppression was enabled by a set of beliefs that were cultivated about Indigenous peoples in Canadian society. So things like they're contagious, their cultures are less capable than ours, they're not good parents. Those were all beliefs that were cultivated about Indigenous peoples that enabled oppressive policies like residential schools, Indian hospitals, and the Indian Act. And those widespread beliefs continue to persist in society today, largely because our systems and institutions are built on the foundation of that settler colonialism and those pernicious beliefs about us. And so as we kind of move into this circle, you see stereotypes. We analyzed multiple data sources in the review to identify the top common stereotypes about Indigenous peoples in healthcare. These were prevalent across every region and multiple healthcare settings that we looked at. So the top stereotypes are listed there. We're less worthy, drinkers, alcoholics, and drug seeking, bad parents, frequent flyers. That term used a lot without any explanation, meaning it must be a very common turn of phrase in the system. Non-compliant, less capable of following instructions, taking care of our well-being, get stuff for free. And then for women, there was this added kind of whammy of misogyny and misogynist stereotypes on top of that, related to, again, bad parenting, sexual promiscuity, availability of women's bodies, squaws was used a lot. So there was this added layer that were very, very specific to Indigenous women. And you can see that the roots of some of those beliefs tie back to those beliefs that allowed colonialism to be accepted within society for a long time. Bad parents was really common back when, and bad parents is common today. Those are profiles about people that we carry in our minds, and often in very subtle ways. And it does shape discriminatory behavior. So abusive interactions, rough treatment of people's bodies, kind of abusive language used, denial of service, a lot of kind of ignoring and shunning. So just taking less time, spending less effort, communicating with Indigenous patients. They're less capable anyway, right? Inappropriate pain management. So drug seeking shifts behavior towards not dispensing pain medication, medical mistakes. So things like, attribution to intoxication as leading to misdiagnosis of stroke or diabetic coma, and disdain for cultural healing. So that it's less, it's inferior healing practice and has no place in the system was common. Now, in your minds, if you can imagine a dotted line across the wheel from discrimination to poor outcomes, that experience of discrimination is associated with poor health outcomes in and of itself. So the experience of facing racism or discrimination in healthcare and reporting that, we found in our data to be associated with higher rates of things like stress and distress and problematic substance use. So just that experience itself associated with poor outcomes, and it also shapes different patterns of access of services. So those environments are unwelcoming, right? If you're profiled and discriminated against, if you have memories of Indian hospital, residential school, those environments are not welcoming. We do have ongoing geographic barriers that are tied into systemic racism and colonialism, where Indigenous communities were relocated and those areas are now underserved by healthcare services. And really concerning to us was this very, very prevalent reporting of mistrust and avoidance of healthcare on the part of Indigenous peoples, right? I'm treated poorly there, or I was treated badly, I'm never going to go back. And that results in much lower GP and NP attachment across all age groups we looked at, and particularly for elders, so 65 and up are the group that faces the largest disparity in GP and NP attachment, which is when often that attachment and continuity of care is most necessary. This contributes to poor outcomes. So as I noted, higher suicidation, higher stress, these kind of typical public health measures that we're familiar with. And you can see that without illuminating the full cycle at play here, how these reports of deficits in the Indigenous population simply feed those stereotypes if we don't understand where those stereotypes come from and how they themselves contribute to poorer health outcomes. So if we hear data out of context about infant mortality, that might feed into our discriminatory belief that Indigenous people are bad parents. So understanding this cycle and laying it out in this way was important to us to be able to identify measures to break this cycle. Back over to you, Mary Ellen.
Yeah, thank you, Harmony. And just picking up what Harmony said about some of those stereotypes that are prevalent at the point of care in BC and how they impact and particularly shape attitudes and experiences of women. Harmony spoke about the bad parent concept. So the bad parent is really focused most often on women because the bad parent information came in through the birth alerts that were in the child welfare system that alerted in the healthcare system to remove children because there was a bad parent or a non-compliant parent. So, and the horrific experience of having children removed at birth is something that we're continuing to grapple with. Birth alerts were just ended now, less than 2 years ago. And the information about families continues to circulate in the system and continues to affect them. And often even hospital staff will remember the parent coming in, the mom who's been there before and had the child removed and the mom's back again. and is really feeling the full impact of that sort of attitude around parenting. So it's about race and it's about gender discrimination. And sometimes it's really about how multiple systems have completely bombarded First Nations families in particular. And so when you think about it, in Harmony's describing the cycle, you know, we do need to reflect on the fact that it's been 5 years since the Truth and Reconciliation Commission made some very strong recommendations, including recommendations that the healthcare system have more skills-based training in intercultural competency, conflict resolution, human rights, and anti-racism. And I just say that because post-secondary institutions and health service providers, you know, have been working in this area for some time. And yet there's a significant need to consider whether the solutions that have been there are working. And hence this slide, which is about, you know, our findings on the problem, that there is widespread stereotyping, racism, profiling of Indigenous people, and that racism limits access to medical treatment and negatively affects health and wellness. Number 3 is a really big finding. Indigenous women and girls are seriously disproportionately impacted. As opposed to all other girls and women, it's quite significant when you look at the health disparities, but also in relation to Indigenous men and boys, because while they're also very impacted in their own way, women's experiences are quite distinct and harsh. The public health emergencies are magnifying this. As an example, Indigenous women have one of the highest confirmed rates of COVID-19, are also very significantly impacted by the opioid overdose epidemic. And Indigenous healthcare workers, whom are disproportionately women, also face significant racism in their work and study environments. We looked at some of the solutions that are there. Some of them are really important. And in British Columbia, there's been significant work by the First Nations Health Council and First Nations Health Authority to build greater understanding in the system, to develop some tools and approaches and agreements to try and promote a more reconciliation-based approach over the last decade. And that work has been very hard fought and has been really significant. At the same time, it still hasn't hit the level of the point of care adequately. So even that work has so much been shunted aside and hasn't hit the front line of the healthcare system adequately yet. So that's one of the reasons why when we examine solutions, we really talk about needing to strengthen and hardwire protections against racism, to promote cultural safety, to protect girls and women in health systems. Next slide, please. Some key observations about women's health that we just would like to share with you today from the report. So we did talk about the misogynistic stereotyping, and we have a couple of emblematic cases. There were hundreds of cases. A couple of emblematic cases in the report about women's experiences. One is an experience of a woman who's undergoing a procedure by a urologist in a hospital setting, and she complains to the urologist that it hurts, it's painful. And the urologist says to her, "I thought you Native women like it rough." So it's a sexist comment, it's a racist comment, and it's also in a very vulnerable time. So it's the sort of comment that has nothing to do with the care, but it has everything to do with the safety of the care. Another example we use in the report that we write about is an example of a First Nations woman who is delivering her baby by C-section because of an emergency, and she's in labor and delivery with members of her family, and the anesthesiologist is prepping her for anesthesia. It's an internationally trained physician, but he kind of stops, looks at them and says, "Is this going to be one of those Native children?" And they're like, "Yeah, we're First Nations." And he's like, "Well, that's too bad." Again, just the sexism, the racism, all of the other people standing there who don't say anything. And so how in that super vulnerable moment for women in particular, but it's also a celebration time. It's kind of like, what is happening here? And so that misogynistic stereotyping is something that we saw a lot of. Indigenous men were 83% more likely than women to feel completely safe when visiting the emergency department. And this is one of the sort of stunning things that we found, was that in the one big specialty hospital in British Columbia Women's Hospital, BC Women's, First Nations women in 2017, 2018 left the hospital against medical advice at a rate which was 11 times greater than any other resident. And that's the whole concept of unwelcoming environment and unsafe environment in a major urban context. Again, pushes against the idea that this is simply a rural remote problem as well. Also, we just share here a little bit of information about Indigenous women have a greater need for healthcare services because the disease burden is much higher for Indigenous people because of the discrimination and segregated care in the past, but often don't have equitable access. So example is Pap screening. So Pap screening amongst First Nations women is 68% of non-First Nations women in BC, yet the cervical cancer rate is 1.6 times higher. So you see these gaps, and again, maternal and child health has a significant gap in terms of lower access by First Nations to health services from prenatal through to the care of young children. And again, there have been innovative and important programs in midwifery and supporting First Nations doulas and midwives, which is significant. It's still building out. It's very small yet, but it's an incredibly important build out because we need much more friendly, positive, accessible, and supportive health services for in the maternal fetal side. Of course, without that, we have a higher preterm and very preterm births and other birth complications for mom and for baby. The other overwhelming finding for women is that the emergency department is the locus or the place where First Nations women receive most of their care. And that was higher than First Nations men, higher than any other women. So really that is not a place to get primary and continuing care, but the absence of the primary care was there. Next slide, please. So just a couple of other observations about poor health across the lifespan. It's not just a women's issue in some sort of like, it's only for women, but women's roles. And I think as Shane mentioned earlier, matriarchs are navigators or heads of family. If a matriarch is sick, it really impacts an entire family. That's the transmission of culture, knowledge, language, law, systems. And Indigenous women are carrying too much of the disease burden. So we talked a fair bit in the report about areas where we are seeing insufficient attention to the health situation of women and insufficient leadership and support for women in health. Next slide, please. So there's a number of recommendations. Recommendation 16 will just draw your attention to about responding to the calls for justice from the Missing Murdered Indigenous Women and Girls Commission. And there is an Indigenous Women's Health report that's been underway for some time. We'd like to see that finished. We'd like to see more specialty services for Indigenous women and enhanced access to maternal, child, and reproductive health care in community and safe screening opportunities and some performance measures as well. Next slide, please. So the reports that we've talked about today, the infographics, which are available for you as well, are all on a site as well. We continue to take cases and complaints. We've recommended there be a new BC First Nations and Métis Health representative and advocate. And while those reports, the report's recommendations are being built out, we have sort of the ombudsman taking the complaints, and I still maintain some oversight of that to make sure that the complaints in real time can be addressed. So I'm just going to end there and just defer to my colleague Harmony if there are any other concluding remarks, because I want to make sure we have some time for some questions.
I'll leave time for questions too.
Thank you so much to all of you for this amazing presentation. I'm just going to go to the chat to find some questions here. So one of the questions is that the Red Women Rising report states that a paternalistic relationship often defines the nature of service provision. Indigenous women report feeling the need to perform politeness and gratitude in order to receive services, which undermines Indigenous women's rights and political mobilization. The construction of Indigenous women as victims in need of help is a continuation of the civilizing savior mentality that deliberately marginalizes Indigenous women. So is this also a finding of the investigation, this need to perform politeness in order to receive services? And are there specific recommendations towards the deconstruction of the savior mentality in healthcare services?
Yeah, I really appreciate those comments from Miranda, that question. And I think that's a really key piece in this report is we didn't use like a victim construct that you need someone who's a proxy savior of women or First Nations people. The whole concept was First Nations peoples and First Nations women in particular need to be in the health leadership roles. And there should be safe, non-sexist care and treatment so that we're not constructing a victimhood. We are actually constructing a safe place is the goal for women to be able to communicate about their needs, not be shunned, to be heard and receive healthcare services they need. So I think that that whole concept, but I really appreciate Miranda raising it, which is this almost constructed idea that, and we saw that, you probably saw the one slide where we talked quite a bit in the report about how women felt the need to dress a certain way, like put on their Sunday best kind of thing so they could get care. Or women also felt that they needed to, like there's an Indigenous woman married to a non-Indigenous partner, and she would send her non-Indigenous partner to get health care and stay away because she felt the children would have better health care if they didn't see her. So these strategies that women have used to survive the system are very gendered. They're racist and they're very gendered because of the lack of respect. And they also require a lot of effort, right? When actually, like, mom wants to be present when the kids have their medical care, and she should be present, and it shouldn't matter who takes the children or if both parents take the children. So this whole idea is like not about a savior mentality. I agree with what Miranda's saying. It's also about not having to promote the stereotype of the good Indigenous woman that will get care. And I think we have to really unpackage that. And I'll just pass it over to Harmy if she wants to share some other thoughts on that.
Well, first, hi, Miranda. It's so great to see you, see your name in this webinar. And I think, you know, it is also about having women like you, like Leslie, like Brittany, others in leadership positions, and for that to be a supportive network for us to be in those spaces and occupy leadership space. So there was a whole recommendation kind of about greater Indigenous leadership, and given the proportion of women healthcare professionals and women that are interfacing with the system, I think having Indigenous women leadership in those positions is really critical. The other thing that I've been reflecting on a little bit is that anti-racism is a really important active concept, but it can also tap into that savior mentality of I'm going to be the advocate that's like out there being anti-racist on behalf of Indigenous people. And I don't want to undermine it. I think that's very important, but that is the counterbalance with cultural humility is yes, be anti-racist, damage those systems that are holding the status quo in place, but also be very reflective about the space that you're taking up in doing so, and ensure that Indigenous people and women also have their own voice. And we all see this in our own families. I see it in my own family as well, where I have to talk to the women in my family about, you know, speak up for better healthcare. But it is something that I think we're highly socialized not to do in many, many ways. Yeah, that's it. Thanks.
Thank you. One of the things that really struck me about the talk was that, you know, you're speaking of racism being a determinant of health for Indigenous women, but also that when combined with the intersections of gender, that kind of no matter what, among Indigenous people, Indigenous women are facing more barriers to care. And I just wondered, do you have some recommendations on kind of what are the biggest steps that we can take towards action, even from a systemic level, beyond training and an individual level, but what can we do in a more systemic way?
Sure, I'll comment on a few of those. I think the most interesting thing is that while we were looking at anti-Indigenous racism in the British Columbia healthcare system, we actually found that, you know, tools related to anti-racism and anti-racist feminism were probably among the most significant clinical tools to also bring to the forefront. And so in terms of some of the key recommendations, as I say, we had 24, so we've got quite a few significant changes to systems, to behaviors, and to beliefs. But making sure that we interrogate these beliefs. And some of the practices in recent times have been to say, like, you know, we have bullying, we have harassment, we have racism, we have discrimination against women. We roll it all up into one like office and we're addressing it somewhere, you know, like in the clinical setting. And one of the things that we really found as we were analyzing it is like, that has actually been a way to not deal with any of it. So it's become this, I know, like in at least one med school, they called it like the office of professionalism, like everything goes there. But then we completely masked the racism, the sexism, and the bias. And it's also interesting because it's also ageism. And we found elders over 65, First Nations elders over 65 have the lowest level of attachment to GPs. And at a time over 65 where you need, you know, regular care, you need to get back up on your feet and so forth. And there's a time when Indigenous women are also in that matriarch role, doing a lot of work, transmitting knowledge, culture through community, grandchildren, and others, sometimes even that they're caring for. So it was like racism, sexism, and ageism. So the tools to take that down and the true accountability in systems to have leaders to understand that, to be held accountable, and not to sort of have one office response, but it's in a clinical setting that it is unacceptable. It can be identified and it can be said that's not, and have that kind of speak up culture to say that's not acceptable here, is really one of the biggest recommendations. So we did recommend that the Public Interest Disclosure Act that's in place, the whistleblower legislation, applies to the healthcare sector immediately. That's been delayed for some time. And in part because this needs to be addressed properly. People shouldn't have to come outside their normal process because issues are not being addressed. And I'm going to ask my colleague Harmony to comment on some of her reflections as well from the review.
In addition to that, all I would contribute is that, you know, we were able to do this review in less than 6 months, and that shows that the data is there. And I would encourage more Indigenous-led. I mean, we had a lot of trust because Mary Ellen and I are Indigenous, and we knew how to work with our partners to ensure that the data could be used and released in a way that upheld their data sovereignty. But it is important that we get more timely and faster production of these kinds of studies that illuminate the inequity and keep the pressure on those accountable for responding.
Thank you. One question that I have, you know, as a researcher working in this space is kind of what can we do as researchers looking at the health and wellness of Indigenous women, and particularly those intersections, to continue to push forward action and the recommendations made in the report?
Yes, I think research is really important. We had sort of like a data governance process here where people shared information, but we looked at health utilization. We were able to get access to row level data. So we were really fortunate, which really speaks to research, because this isn't really an advocacy report so much as this is what the evidence and research says, but it also shows you why things like disparities in cancer screening or maternal fetal care, this has to actually really be analyzed and in a site-specific way, like by region. So I think having access to data sets to do research in an ethical way with First Nations and Métis communities and service providers, I think is really important to build that out and to build out the understanding for it. So we were able to, as Harmony says, launch pretty quickly and engage a lot of people through networks that we had, and there was some trust in the work, but there was a lot of mistrust of the system. And I feel as though we did only scratch the surface, and we were looking at the treatment of women. And I see there's a question in the chat about, two-spirited LGBTQ plus. We did not even get to go into gender diversity adequately with respect to the review, because we were just got so much in particular from women, and there needs to be more targeted research in that area, right? It was enough to tell us there's more work to be done, but we just kind of opened the door to it. And we think that there should be additional work completed. And I'm going to pass that over to Harmony as well to see if she wants to weigh in on that.
I think that was excellent. I think this type of report just generates a lot of research questions. And so we do hope that that it's created some space for Indigenous researchers and others to be looking at these issues.
Thank you. We have one question here around, can you comment on accountability and tracking of human rights violations in institutions going forward, and some of the limitations of implicit bias training?
Yes, I think there's a lot of limitations. First of all, in terms of anti-Indigenous prejudices, it's incredible how widespread they are, even in other communities where there's people of color. And it's part of not having proper training. And there are just these really deep, persistent racial biases that are significant. So I think some of the training approaches that we've encouraged, anti-bias training, I think it's got merit to some level, but we actually need to really have clinically based anti-racism and anti-sexism tools. And there has to be that real training in that clinical setting. And in terms of kind of complaints and processes, we really found that, first of all, Indigenous people, there's this thing like they don't want to use the complaints process because they can't be bothered. Actually, it was completely different. They want a complaints process, but what they found was when they did complain, they would sometimes end up in a process with a health provider that said, but I'm not racist, but I'm not racist. I don't understand what your problem is. That's not me. And and there was no kind of proper intermediary saying, whoa, stop. Someone has to prove the issue and then deal with the overwhelming response of the system, which was not safe and appropriate. So the accountability piece is really important. There needs to be the ability to bring complaints forward. We really wanted to see complaints. If you're in a region, you should be working with the First Nations of the territory in the region to think about what are the cultural practices and protocols to deal with complaints. How do you bring it down? So you have knowledge keepers, you have processes right there to address it properly and with a strong cultural lens. And that is something that's really missing. We also found in the regulatory colleges and those processes for complaints about professional conduct, they're not friendly processes. They're difficult to navigate and they take a long time and they don't return back to the clinical setting, which isn't saying they shouldn't proceed, but we really took a strong lens as what happens at the point of care. So we really feel that this should be unpackaged at the point of care and should be unpackaged by Indigenous people within and with the healthcare system, and be very regional in British Columbia and very connected to the First Nations. So we wanted a standard for cultural safety, cultural humility, but we wanted operationalized in the setting of the region and with the First Nations of the territory. And that's important because these very pan-Indigenous attitudes that people have about Indigenous people are inaccurate. And so we wanted to start to take those down. And I'll just turn it over to my colleague Harmony for her to give some reflections on what she thinks are some of the most important changes.
I think that there's a natural human tendency to take a course and then feel like you've checked off a box. And ultimately this work is about continuing practice and continuing to improve our practice as human beings. So I think that training and education is a lifelong endeavor and has to include gateway, high-level awareness raising aspects that then just stimulate an ongoing journey that relates to your particular practice as a human being, as well as what your role is in the system. And so we're recommending, as Mary Ellen's described, kind of point of care and territory-based aspects within a broader continuum of learning.
Thank you so much to both of you. I know that we're at our time now, but I just think it's so amazing that we've had this conversation about bringing to light and some of the truth telling of what's been happening for Indigenous women in BC. And as Shane pointed out, the strong women in our communities kind of hold everyone up and keep our communities well. So I think it's a wonderful thing for us to touch on for International Women's Day and think of how we can better support Indigenous women going forward. So thank you again. I'm so grateful to both of you for the presentation. And I just want to pass off to Shane if he can maybe wrap us up.
Thank you for that. In my thinking, where we are at right now is an awakening. Canada, British Columbia, has been in the dark, in willful darkness about who Canada is and British Columbia. They perpetuate this, we are a wonderful, wonderful society, we're multicultural, and we love everybody and we welcome everybody. And that's just not the truth. Truth is that racism exists not only to Indigenous people. Racism, I was looking at the screen and there's many of you who are from other parts of the world and Indigenous to there. You have dark skin. I'd imagine that you and your families have many histories of racism pointed at you directly. I believe Canada and British Columbia in particular need to acknowledge the fact that racism exists, that sexism exists, that the treatment of women, not only Indigenous, but all women exists, and accept that fact. It's in the acceptance of that fact that everything gets to move forward. As I listened, the young lady asked the question, what do we do? Well, it's an individual endeavor to be a better human being, to have the courage to stand up to injustice of systemic racism and sexism, violence towards women and children. It takes courage to look at a man of European ancestry and say to them, what you just did was wrong and hurtful. That takes courage. because you know for yourself that that man is steeped in white privilege, economic privilege, and they'll just think that you're silly. And what are you talking about anyway? I find that the upper echelons of society is a really sad and sick place, because there is no acknowledgement of others or acceptance of others. So my message always is Natsama, we are one. I work towards every day that end. And hopefully one of my daughters will pick up that work. My granddaughters are thinking about it and picking up that work of oneness. We need to be Natsama, Shkwalon, one heart and one mind, so that we are all healthy. I want to say to all of the women who are here, thank you. Thank you. Thank you. I'm grateful to my mother, my aunties, my grandaunts. I'm grateful to them. I'm grateful to my daughters, my granddaughters, and my great one. I know that through your work as women, life, not just now, but 7 generations from now, is going to be way better than it is now. The system that is in place has been in place for thousands of years. To unravel that is going to take us a while, and we've begun. We're in a new beginning, and that's beautiful to me. We need to remember that systemic racism is thousands of years old. The monarchies of Europe, the presidents and the prime ministers of Canada, steeped in white privilege. It's going to take us a while. And if we all work together in a good way, with a good heart, that's going to change. So on this very auspicious day for women around the world, I want to say thank you to all of you. All of you, thank you. And I encourage you, maintain your courage, maintain your strength, and always do your best. The founding CEO of First Nations Health Authority, what was constantly in Joe Gallagher's mind wasn't just about how can we provide health care today, but how can we provide positive health care over the next 7 generations? How do we do that? And he often said we do that by how we show up. And we show up with courage, and we show up with intention to treat our fellow human beings with the dignity and the humanity that they deserve. So thank you for listening for these few moments. Please take care. My wish always is for everyone to have fun. So take care and have fun. Thank you very much.